name is Kate Chesterman. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify and Apple and Google podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today I'm going to be following on from the podcast I recorded on Pityriasis versicolor a few weeks ago, and we're going to be considering Pityriasis rosea, which is another common condition presenting in primary care. Like we saw with Pityriasis versicolor, in Pityriasis rosea the name describes the condition. Pityriasis is a skin disease characterised by the shedding of fine, flaky scales, and rosea describes the pink red patches that are frequently seen in this condition. Pityriasis rosea is a common and self-limiting condition. It frequently occurs in children and young people between the ages of 10 and 35, and affects women slightly more than men. In temperate climates, it's more common in winter months. The cause is unknown, although viral and bacterial causes have been hypothesized. The strongest evidence seems to be an association with herpes viruses 6 and 7, and a possible reactivation of these viruses after an asymptomatic primary infection. The hypothesis of an infective cause is backed up by the findings of seasonal variation, familial clustering, and a prodromal illness that is experienced by many. Despite possible infective causes, Pityriasis rosea is not contagious. There have also been non-infective causes suggested, and a drug-induced Pityriasis rosea can be seen that mimics the rash of idiopathic Pityriasis rosea. It's worth considering drug causes, especially if the rash occurs in the elderly and if it does not improve within the expected timescale, as it will usually only resolve on discontinuing the causative medication. Common triggering medications include, among others, ACE inhibitors, antibiotics, biologics, and non-steroidal anti-inflammatory drugs. It has also been reported after a variety of vaccinations, including the BCG, influenza, polio, DTP, and COVID vaccines. So, how does Pityriasis rosea present? Well, in around 2/3 of cases, patients may experience a mild prodromal illness that can include mild headache and fever, tiredness, sore throat, and lymphadenopathy. The first dermatological sign is typically the herald patch, and this is seen in up to 90% of cases. The herald patch is usually salmon pink to bright red, round to oval, and 2 to 5 centimetres in diameter. The patch is slightly raised with a well-demarcated border and is described as having a fine collarette of scale, which means that scale is present at the periphery of the patch, just inside the edge. The herald patch is typically found on the trunk, thigh, upper arm or neck, but rarely can be found on other locations throughout the body. Up to 2 weeks after the appearance of the herald patch, a more widespread rash develops. This involves many small oval patches that range in size, usually up to 1.5 centimetres in diameter. These patches also commonly have a collarette of scale with a central wrinkling of the skin. In light skin, the patches are usually a pink-red colour. In skin of colour, they can be grey, deep brown or black. The rash is commonly found on the trunk, neck and proximal limbs. The hands, feet and face are usually spared, although the face can be affected in children. Oral lesions can also occur. The patches usually follow the relaxed skin tension lines or Langer lines on both sides of the upper trunk. This means they run in the same direction as the ribs and are often described as having a Christmas tree distribution. Worsening of the rash, or a second wave of lesions, is not uncommon before spontaneous resolution, and patients may need reassurance that this is not unexpected. In most patients, the rash resolves within 6 to 8 weeks. After the rash is gone, some patients may be left with hypo or hyperpigmented patches, and this is more obvious in those with darker skin tones. The pigment should return to normal within a few months and won't leave permanent scarring. Good images of the Herald patch and subsequent rash can be seen on the Primary Care Dermatology website, and there is also an excellent patient information leaflet on this website that can be very helpful for your patients. There is a link to these resources in the show notes to this podcast. Atypical variants of Pityriasis rosea occur in approximately 20% of cases. These variants differ from the classical presentation and may include an atypical morphology, an unusual size or distribution of the lesions, an atypical herald patch, a prolonged course or severe symptoms that can make the diagnosis more challenging. Children are more predisposed to atypical variants compared to adults, possibly due to atopy. Alternative diagnosis should be considered in the presence of blisters within the lesions, if the majority of lesions are found on the palms or soles, or if there is clinical or serological evidence of secondary syphilis. Differentials that should be considered include, among others, secondary syphilis, tinea corporis, erythema multiforme, guttate psoriasis, viral exanthems, or even cutaneous T-cell lymphoma. So how should we treat Pityriasis rosea? Well, the rash will spontaneously resolve, but patients may need symptomatic treatment as the rash can be associated with itch, and this can be severe in some cases. For many patients, the avoidance of soaps and body washes and the use of soap substitutes and emollients will be sufficient. Others may require mild to moderate topical steroids and oral antihistamines to help with the itch. There is limited evidence that early antiviral therapy with acyclovir may be beneficial in some cases. However, the evidence is conflicting and it is not recommended for all patients. Its use could be considered in those with severe pruritus, extensive rash or early disease onset, but for most patients with mild to moderate conditions, supportive treatment with topical corticosteroids and oral antihistamines remain the preferred treatment of choice. Discussion with dermatology, if you are considering the need for antiviral therapy, may be worth doing. Complications are thankfully rare. Patients could develop a superimposed bacterial infection secondary to scratching that may require topical or oral antibiotic therapy. A prolonged skin discoloration is seen in a small minority, and there have also been reported cases of a severe cutaneous adverse reaction due to reactivation of herpes virus 6 or 7 in association with a drug. There have also been reports of early pregnancy complications, including miscarriage and premature delivery, when Pityriasis rosea is contracted in the first 15 weeks gestation. Thankfully, these outcomes are rare, and the vast majority of pregnancies affected by Pityriasis rosea result in healthy deliveries. Recurrence is also rare, affecting less than 5% of cases, and multiple recurrences are extremely uncommon. In recurrent cases, the herald patch may be absent, and the size and number of lesions may be reduced. If there are diagnostic doubts and atypical symptoms, such as a prolonged rash or severe symptoms, then seeking guidance from dermatology is a sensible option. A dermatological opinion can be helpful for ruling out other differentials, as well as managing difficult cases. Phototherapy treatment is sometimes advocated for those with extensive or persistent rashes and may be considered by the dermatologists. So, thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com. Feel free to email support@GPnotebook.com if you have any questions, comments, or ideas for future podcast episodes. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.